So the reason that the late cyanotic lesions can actually end up causing cyanosis is something called Eisenmenger syndrome. What happens in this situation is that there is a shunt somewhere in the heart that allows blood to flow from left to right. Not a big deal because we're losing a little bit of oxygenated blood shunting into deoxygenated blood areas. So which lesions did we just discuss that could lead to an Eisenmenger syndrome-like presentation? Anything that allows the communication between the left and right side. That includes ASD, a VSD, a PDA, right? This is a key point for us to review one of the ways in which a patient with a congenital heart disease can develop pulmonary hypertension. We have already said that the patient has to have a shunt somewhere that is allowing an increase in flow into the pulmonary vasculature. So let's incorporate some physiology here because that is how your test questions will come. That is how test question writers like to think when they're coming up with these fun questions we all love trying to answer. So, we all know that a change in pressure equals flow times resistance. And this is that equation P equals Q times R. We also know this equation because we discussed it in the physiology section. But let's change some of the values into terms that will help us understand the pathophysiology of Eisenmenger syndrome. So let's rewrite this equation as the pulmonary artery pressure minus the pulmonary venous pressure. So pulmonary artery pressure minus pulmonary venous pressure equals Q times pulmonary vascular resistance. So remember that Q here is flow and PVR is pulmonary vascular resistance. So flow is the exact same thing as the right-sided cardiac output because that is what's controlling how much blood is being pumped into the lungs. So just look at this equation for a second. We are worried about pulmonary artery pressure, so let's subtract pulmonary venous pressure over to this side. And we have pulmonary artery pressure equals Q times PVR minus PVP. And remember that pulmonary vascular pressure is equal to the pulmonary capillary wedge pressure. Remember, we used our Swan-Ganz catheter to occlude or block a tiny branch of the pulmonary arteries to create a continuous column of static blood that allowed us to detect the pulmonary venous and left atrial pressures because we can consider them as one continuous static chamber of blood when you wedge a catheter in there. So now we have an equation that says pulmonary artery pressure equals flow that's within the pulmonary artery, which is our right-sided cardiac output, times the pulmonary vascular resistance plus the pulmonary capillary wedge pressure. There are several ways that we can change the value that we calculate for here, which is pulmonary artery pressure. Remember, we are worried about the pulmonary artery pressure because Eisenmenger syndrome is high pulmonary artery pressure. You need a combination of increased flow and increased pulmonary vascular resistance to get this value to go up high enough where it's a problem. Why can't we just increase flow a lot like we would expect in the case of a large VSD? Well, remember that when you initially get increased flow through the vasculature of the lungs, vessels are recruited, and vasodilation occurs to help prevent and alleviate some of the potential increases in pressure. So over time, we will have so much increased flow through the pulmonary vasculature that we accumulate the effects of continual shear force on these vessels. So if you think about it, you have your pulmonary artery trunk, or whichever part of the pulmonary artery you want to talk about. There's so much flow here that these vessels are lined with endothelial cells, and their endothelial cells get sheared from shear force from high flow and volume. These endothelial cells are highly active cells. They release things they store when they get damaged from this continual shear force. They release endothelin-1 because they're damaged. They can't contain it anymore. This causes vascular smooth muscle constriction, right? It makes also vascular smooth muscle cells migrate into the intima. As you can see here, the intima has a lot of hyperplasia and vascular smooth muscle cell involvement. So endothelial cell damage from shear forces and volume overload in the pulmonary vasculature causes release of endothelin-1. This causes vasoconstriction and vascular smooth muscle cells to show up in the wrong places, such as the intima. Now, what else happens when we damage these endothelial cells? We lose the ability to produce good things like vasodilating agents such as nitric oxide. So in addition to all the things that occur from endothelial cell damage, from increased hydrostatic pressure and shear force, We release endothelin 1, causing vascular smooth muscle cell vasoconstriction. As you can see, look at the size of the lumen. We lost our nitric oxide, and we also release von Willebrand factor that is stored in the Weibel-Palade bodies of the endothelial cells lining these pulmonary vasculature endothelial cells. So this is a great time for us to review the clotting cascade and how it contributes to some of the tiny thrombi that can be seen in the vessels of the pulmonary vasculature bed in patients with Eisenmenger syndrome. I know it's terrible, but it's a great time for us to review the formation of a clot and platelet plug. Okay guys, so remember, von Willebrand factor in the pulmonary vasculature is released from the endothelial cells because they're continuously exposed to shear force, and when they're continuously exposed to shear force, they don't like it, they die, they release whatever they're holding. The Weibel-Palade bodies contain von Willebrand factor. It is a large glycoprotein produced in endothelial cells, stored in Weibel-Palade bodies, and it's also present in subendothelial tissue. So when shear stress damages our vessels, we expose the subendothelial collagen and release von Willebrand factor. The binding of von Willebrand factor to glycoprotein 1b or IB, it has been said many different ways, causes the release of ADP from within a platelet. Now what does that do for us? Well, it binds ADP receptors. These are actually called purinoreceptors, which makes sense because any purine can bind them. Clopidogrel is a drug that mimics purines and blocks these receptors. So let's say we do activate these purinoreceptors or ADP receptors on the platelets because we induced ADP release by binding GP1B with von Willebrand factor. What happens? Well, we get an increase in intracellular calcium and we get a conformational change and a continued production of ADP. Conformational change you always hear about just means that we change the surface of the platelets. This exposes GP2B3A complexes. They were previously hanging out in the clefts that were hidden before the conformational change. So the binding of ADP to purine receptors, or ADP receptors, potentiates these conformational changes. These newly exposed GP2B3A receptors will bind fibrinogen, as you can see here, and helps in the formation of a platelet plug. So, for a really complete review, let's remember which diseases are associated with the different components listed here. So for von Willebrand factor, not a big deal, that's von Willebrand disease. For any problem with these GP1B or IB receptors, that is Bernard-Soulier disease. Last but not least, don't forget about your boy, Glanzmann, and that is associated with Glanzmann's thrombasthenia, which is due to a mutation of the subunits 2B or 3A of the glycoprotein 2B or 3A receptor. So again, let's summarize. We get endothelial cell dysfunction, we get vasoconstriction, and we get thrombi blocking our vessels. And all this is related to shear force on our endothelial cells of the pulmonary vasculature. So if you look back at the equation, pulmonary artery pressure equals Q times PVR plus our pulmonary capillary wedge pressure, which is the same thing as pulmonary venous pressure, we end up significantly increasing the pulmonary vasculature resistance and the flow in someone that has had some sort of chronic abnormal communication between the left side and the right side of the heart, causing pulmonary vasculature blood overflow. So what does the right ventricle think about this? Because we have such a high increase in the pulmonary artery pressure. The high pressure or afterload created by this remodeling and hypertension in the pulmonary artery causes compensatory concentric hypertrophy of the right ventricle. So we have right ventricular hypertrophy. And remember, concentric is towards the middle, so we get a decreased diameter of our right ventricular chamber as well as increasing the thickness of the right ventricular myocardium. Eventually the pressure in the right ventricle will build up so high that the shunt will reverse. So we're back here, and if you see, eventually we will reverse the shunt, and this arrow represents that perfectly. There's hyperplasia, proliferation of tissues, vasoconstriction here. This pressure gets really high. There's no need to go into that area anymore. It does not follow physical properties. Blood will flow from right to left, and now we have reversed our shunt. This means that we will completely bypass the lungs because the right ventricle cannot generate sufficiently high enough pressure to pump into the pulmonary trunk. It takes the path of least resistance across the whatever defect we're talking about and to enter the systemic circulation. So in the situation here, you can see this VSD is the defect. the shunt reversed, and now blood is flowing without entering the pulmonary vasculature whatsoever. This is really bad because there's no oxygenation of blood at all. We bypass the lungs completely. That means that we're putting low oxygen blood directly into the systemic circulation and into the descending aorta. This is how late cyanosis develops. These events and changes take time. So you see things such as clubbing, polycythemia, which is an increase in your red blood cell count. But why? Well, when your body senses that you're delivering very low oxygen tension blood everywhere in our body, we induce the transcription of hypoxia because we are in fact hypoxic, inducible factor. This occurs in the kidney. Hypoxia inducible factor causes changes that will help increase our oxygen tension in the blood. It releases platelet-derived growth factor, vascular endothelial growth factor, and erythropoietin. These circulate in our blood and eventually stimulate cells in respective areas. Platelet-derived growth factor stimulates fibroblasts within the nail bed, which causes excessive collagen deposition that gives us the classic nail clubbing look, while vascular endothelial growth factor stimulates angiogenesis. And the last one, which is very important, is that erythropoietin stimulates erythroblasts to make many, many more red blood cells, and that is why we get polycythemia. Excellent, we did a great job with that. Now, another flash quiz is upon us. Tetralogy of Fallot is caused by the displacement of what structure during embryogenesis? The infundibular septum. Remember, we just discussed this. It is an anterior and superior displacement so that the right ventricular outflow tract is very stenotic, and we usually have an associated VSD from this displacement. Here again, we see the displaced anterior and superior septum with a VSD, the stenotic outflow tract for the right ventricle that leads to right ventricular hypertrophy, and we get the classic boot-shaped heart. So we've seen this image before. We've seen this little protuberance here of the right ventricular outflow tract that occurs due to the displaced descending infundibulum. Tetralogy of Fallot is a particularly high-yield one. Make sure that you know this backwards and forwards. It will be on your Step 1 exam in some way or the other, or at least the concept behind it will be.